Everybody, and especially the organizers of KCRS for giving us this time to talk about a very important topic, something that's important to us all in this room as medical oncologists, urologists, patient advocates, basic science researchers. I think this really drives at not only the biology of kidney cancer, but also clinical practice. Before we go into our formal introduction, I'm going to ask Samantha if she can hold my cell phone.
Yes. And my cell phone is actually in the back taking a time lapse of the ink factory, so I do not even have one to offer back. But we encourage everyone to join us in this conversation and really think about what it means. This is one of the first sessions in maybe 7 years of KCRS that we're shifting the focus from the patient that sits in front of us to the family that joins them at the session and what we need to be doing for them. So for many of you that order genetic testing and think about these realms, in the world of accelerating cures, we really work in this disease model, right, where we treat the patient and we're trying to get to a cure faster. But what would it look like if we started sooner, if we identified individuals that were, we have good guidelines, as we'll hear in a second, when you're germline positive, but what happens when you have a family history of kidney cancer and what we can be doing. And so this came together kind of really as a brainchild, and we're really excited to engage in that conversation today and really think about a slightly different population than the conversation we typically have. With that, I'm going to invite up Dr. Marie Carlo to start us off.
Thank you for the invitation to speak, and thank you to the moderators because they did a great job assigning us learning objectives and things you wanted to hear about. So in hopefully 7-ish minutes, I hope to discuss which patients to refer and what our guidelines say, kind of some real-world evidence regarding germline genetic testing, and finally, some emerging associations with genes and phenotype. Starting out with a case, you have a 39-year-old woman. She was found to have an incidental renal mass. She's healthy. She has a nephrectomy. She has clear cell. No family history, nothing else. Do you offer germline genetic testing?
Can we pause for a second? Show of hands, how many people would offer genetic testing to this patient?
Oh God, we've been doing our job.
Good. So what do our guidelines say? Fortunately, we have pretty good, I think, simple and concordant guidelines. So both NCCN and the AUA have very similar rules of who to consider or recommend genetic testing. The cutoff for considering genetic testing is age 46. And that is due to a study now almost 10 years old from the NCI that showed that this age you would maximize sensitivity and specificity for catching people with genetic RCC syndromes. So our patient would qualify under that rule. So under following guidelines, consider referral and recommending. Also multifocality, multiple renal masses, positive family history, or a pathology suggestive. So this is your FH deficient RCCs, SDHB deficient RCCs. Now, 46 and under covers a lot of patients. So I thought I was seeing more younger and younger patients in clinic, but I'm not crazy, it's true. So this paper just came out in Cancer Discovery, showing that the incidence of kidney cancer overall is growing, especially in the young folks. And it's among the 4 cancers with the largest absolute increase in young cases. So young cases meaning 30s and 40s. So we are seeing this more in clinic. So young onset covers a lot of patients. Should we be sending all of them for genetic testing? So we actually looked at this in our institution a couple of years ago. We looked back at all our young patients, 46 and under, who had had germline genetic testing, and tried to figure out what predicted them having a positive result. So among 232 patients, either had genetic testing for whatever reason or were specifically referred, 9% had a mutation in an RCC gene. And you can see, those with multifocal tumors, about 30, so the blue is the percent of patients, young patients with RCC who had a positive genetic result in an RCC gene. So you can see that about 30% of those with multifocal tumors had a positive result, about 30% of those with a prior cancer history, say a little bit less for family history or non-clear cell subtype. But looking at those with clear cell and nothing else, so you're a 39-year-old with a clear cell, no family history, no other feature, we actually picked up 0 RCC gene mutations out of 91. So again, that's a single center retrospective study. I haven't changed my practice. I still refer that 39-year-old for genetic evaluation. Also, this is like based on our history, right? We took a good family history because there may be some hidden, cancers in the family that you pick up only with a good genetic counselor. But I do counsel my patients, that 39-year-old, I would tell her I recommend genetic testing, but probably it's gonna be negative. We don't know why young people are getting kidney cancer, but we're looking into it. So looking back at the guidelines, one thing that I do practice, and hopefully the NCCN will consider adding to their guidelines, is a personal and family history of mesothelioma and uveal melanoma. So I ask about this because of BAP1 tumor predisposition syndrome. Relatively newer syndrome. It is autosomal dominant, very high lifetime cancer risk, probably more than almost all our other syndromes. And there's some emerging cancer associations. Hallmark cancers, uveal melanoma, mesothelioma, just general melanoma, and then kidney cancer. Now, and this is probably best illustrated by this patient that Ari Hakimi and I share. She's the 39-year-old. Her dad was found to have a BAP1 mutation when he was seen at our institution. She had her first kidney cancer at 39. Then she was diagnosed with endometrial, ovarian, adult granulosa cell tumor, which, fun fact, in BAP1 mouse models, the most common tumor they get is sex-cord stromal tumors with BAP1 deficiency. She had a second RCC, which interestingly was just a low-grade oncocytic tumor. It didn't have a VHL mutation, but it had a second BAP1 mutation. On screening after her surgery, she was found to have this pleural effusion. She had mesothelioma, and then actually the tumor she's being treated for right now is a metastatic adult granulosa cell tumor. So this is just to illustrate we're still learning a lot about BAP1. If you have a BAP1 patient, you still need to screen for other cancers. And because sometimes, for example, the mesothelioma is not the active cancer for her. I'm gonna, in the interest of time, show you, they're, again, still learning a lot about BAP1. Some interesting observations just published in the last year. So our group, on the left, you can see these splenic lesions. We noticed in retrospective study that about 30% of our patients had splenic, BAP1 positive patients had splenic lesions. These can be FDG avid. This patient had a resection. They all ended up benign. So benign vascular lesions, unclear what they are. They're possibly BAP1 driven. This patient had equivocal BAP1 staining. The NCI just published this report on the right that BAP1 patients have these onychopapillomas. So you can see a patient you suspect BAP1, look at their nails. So again, learning a lot about it. Maybe a minute on CHEK2, because this is probably the one I get the most questions about. CHEK2, DNA damage repair gene, definitely a tumor suppressor, very common to have a mutation in the population. This particular mutation, 1% of Northern Europeans. There's definitely for this one mutation, which is the best studied, there's an increased breast cancer risk, but controversial whether there's other cancer risks. So just to illustrate this point, the NCCN used to recommend colorectal cancer screening for CHEK2 germline positive patients, and then last year they took it out. So it's really unclear what we should be doing beyond breast cancer screening. Prostate, possibly. CHEK2 is also the gene that has the most conflicting interpretations on ClinVar. This is the central repository where labs put their interpretation of different variants. And this is due, again, there's about more than 3, but at least 3 very common mutations in the population, and everybody's all over the place. They do appear to be a little bit less penetrant than the 1100 del C I just showed you, but unclear what even their risk of breast cancer is. So CHEK2 is common in our RCC patients. Is it because it's just common and they happen to have kidney cancer, or does it cause kidney cancer or contribute to the kidney cancer? I think still jury's out. There was this nice paper by Eliva and Allen group where they looked at kidney cancer cases and the particular variants, and then they stratified it by population, so comparing Northern Europeans to Northern Europeans, and they found the association with kidney cancer was lower than other studies. So I'd say the jury is still out. In my practice, I do not screen CHEK2 positive patients for kidney cancer, but I have the conversation that, you know, come back to us in 1 to 2 years because we might tell you screen for colon cancer, screen for breast cancer, don't screen. So just so you understand that. And a little over time, but hopefully I covered some of the learning objectives.
Okay.
Excellent. Thank you.
Any questions? Okay.
I think we have time for maybe 1 or 2 questions in between sessions, and then we'll have some time at the end as well. Yes?
They're coming with the mic. We should get a step count on you guys by the end of the day, by the way. Really getting your exercise in.
Hi. Thank you, Tony. For the CHEK2 and breast, does that include you would screen for a male patient?
Great question. Currently, there's no guidelines to screen for male patients. There are some studies, at least for the loss of function, the 1100 LC showing an increased risk of male breast cancer. The incidence is still so low. You know, the only cancer that we routinely recommend screening or to consider is still BRCA2, which definitely is an increased risk. So CHEK2 possibly male breast cancer risk, but we're not screening.
Yep.
That was a wonderful talk. Thank you. In the past decade or so, there's been quite a few GWAS studies that have been identifying these low penetrance genes that may be associated with kidney cancer risk. But as far as I know, there's no way to test for these yet in the clinic. Is this something that you guys are thinking about? Is there any way this is going to come to the clinic anytime soon?
Yes, and I was tasked to talk a little bit about GWAS, but honestly, time is tough. Yes, we're definitely thinking about it. It's more mainstream for breast, now prostate cancer. I think in the future it will come to kidney cancer, and then essentially you'll come with your, holistic, your high penetrance variants like FH, but then also your PRS score. Kidney cancer is also a cancer that's easy to screen. It's non-invasive, plus the tumors tend to be slow growing. So I think it's an ideal cancer if we find the right candidate to screen.
I'll also throw out there, just from the breast and prostate, in a germline testing laboratory, they used to combine germline testing with polygenic risk scores in the breast and prostate space, and then took that away because they hadn't actually done validation across all ancestries and different backgrounds. And so I would say polygenic risk scores and some of that work has actually taken a step backwards in terms of clinical implementation in order to be studied further. And so I would hope that it goes further, not just for the common cancers, but that's one of the challenges I think people are finding in terms of reimbursement, et cetera, that clinical practice didn't really yield what it needed to yield to be clinically utilitarian.
So our next speaker is Dr. Mark Ball, who is a urologist from the NIH who has an interest and specialization in hereditary kidney cancers. He's going to talk a little bit about some of our common screening for those with known variants, and then also some of the emerging modalities for early detection of kidney cancer.
Thank you so much for the introduction. Thank you to the organizers for the invitation, and for the moderators for putting together this session. So the objectives over the next few minutes, I'm going to talk about the risk of RCC among the various hereditary kidney cancer syndromes, and also envision a role both for conventional and novel functional imaging and screening and managing these patients with hereditary syndromes. I think we all know that the kidney cancer is not one disease, but many, and this is a paradigm that was put forth by my mentor, Dr. Marston Linehan, and we know that these are different diseases that happen to arise in the same organ. They're driven by different genes and have different biological behavior, but germane to this topic, I think they also lend themselves to different imaging, surveillance, and screening strategies. That has to do with both the risk of RCC and sort of tumor growth kinetic differences between the various histologies. So if we zoom in from those dozen or so in the last slide to the four sort of most best described syndromes, there is a considerable difference in the lifetime risk of RCC among these. So maybe the one that we're most familiar with, von Hippel-Lindau syndrome, has about a 40% lifetime risk of developing kidney cancer, while a disease like hereditary papillary renal cell carcinoma, HPRC, has an almost 100% risk of developing a solid tumor over a patient's life. Birt-Hogg-Dubé, folliculin-driven disease, 30% risk, and HLRCC has around a 15% risk of developing kidney cancer. Now, if we see one of these patients in clinic and they don't have a kidney tumor, when do we screen them again? For those first three, at our institution anyway, we tend to screen these patients every 3 years if they don't have evidence of a tumor. Now, it's very different if they do and we're doing active surveillance, but screening for new tumors every 3 years. But the one at the bottom, HLRCC, different beast entirely. We don't do active surveillance for that, and we don't like to go more than 1 year without screening these patients because they can be quite aggressive. Now, if a patient has a tumor, we sort of shift from screening to surveillance. And what screening intervals do we do for surveillance? Well, we did a study a few years ago looking at growth rates of tumors of patients with hereditary kidney cancer syndromes and found that there were distinct growth rate differences among the various syndromes. So in this study, patients with BAP1 altered tumors had rapid growth, over 0.5 centimeter a year, 6 millimeters a year. Patients with VHL, sort of intermediate growth between 3 and 4 millimeters a year. Patients with MET-altered or folliculin-altered tumors that we see in HPRC and Birt-Hogg-Dubé had slow-growing tumors, 1 to 2 millimeters per year. So that's nice, but how does that translate to the clinic? Well, in an era where we want to not over-image patients, because this is lifelong risk, right? We don't want to be too burdensome, but at the same time, we don't want to miss the window to intervene. This can make big differences in our surveillance schedules. So imagine 4 different patients, all with a 2.5 centimeter renal tumor. In the first column, a patient with Birt-Hogg-Dubé. That patient we might image again in 2 years. Why? These are slow-growing tumors, 1 to 2 millimeters per year. And in 2 years, that tumor may still not reach the threshold at which we would intervene. For this particular syndrome, we intervene when a tumor reaches 3 centimeters. Contrast that to column 2, a patient with von Hippel-Lindau disease, a patient with a 2.5 centimeter renal tumor. We're going to image them again in 1 year, at which time it's likely going to be close to the size where we would want to intervene. A patient with BAP1, we heard that in the last talk a little bit about BAP1. These tend to be faster growing tumors. And so for a patient with a 2.5 centimeter BAP1 tumor, 6 months might be the interval, if not talking about early surgery. And finally, in the last column, HLRCC. Again, these can be very aggressive tumors. We don't do active surveillance at all. So if we see a solid tumor, we're not recommending repeat imaging. We're booking that patient for treatment. Now, with conventional imaging, we can glean more than just the tumor size or maybe the growth kinetics. We can also leverage different parameters on multi-parametric MRI. So we have an active collaboration at our group at the NCI along with the imaging group at the NIH Clinical Center using multi-parametric MRI to characterize hereditary kidney tumors, and that's led by Ashkan Malieri on the radiology side. This is one collaboration we did. We developed something we called the Kidney Imaging Surveillance Scoring System, or KISS. And what we wanted to do was to pick a couple of features that were high yield to predict fast versus slow-growing tumors among patients with von Hippel-Lindau disease. And using just 2 features, is a tumor predominantly solid or cystic, or does a tumor have restricted diffusion or not, could really stratify if a patient is at risk for a faster-growing tumor. So if they have both of those characteristics, a solid tumor with restricted diffusion, those tend to be faster-growing than the opposite. And that can also further tailor our imaging schedules for these patients. Similarly, we leverage diffusion-weighted MRI to characterize patients with HLRCC tumors. And with HLRCC, because we intervene when these tumors are small, it sometimes is difficult on conventional imaging to determine, is this a solid mass? Is this a complex cystic mass? Maybe it's a hemorrhagic cyst. How do we differentiate? And one way that we have found to do that is using ultra-high B-value DWI imaging. So in this study, we had multiple radiologists, both sort of more junior and more senior, and we found that among more senior radiologists that the addition of high B-value DWI increased the likelihood of detecting malignancy and with the gold standard compared to surgery when these tumors came out. So really a lot of value in using DWI for these patients. Moving on from conventional imaging, is there a role for functional imaging for patients with hereditary kidney cancer? And I think there are really two areas where there is a role. One is for patients with HLRCC. I think most of us know that HLRCC, these patients have biallelic loss of fumarate hydratase. So not only can these tumors with biallelic loss not complete the Krebs cycle, but they also have accumulation of oncometabolites like fumarate and succinate that effectively poison the electron transport chain and making these tumors dependent on aerobic glycolysis. For that reason, these tumors are incredibly FDG PET avid. You can see on the graph on the right that compared to background, patients with papillary type 2 tumors seen in HLRCC have very avid tumors on FDG PET, more so than any other kidney cancer tumor subtype. And so oftentimes we think PET, not useful for kidney cancer. It's probably true for most cases, but for HLRCC, there's a role in both localized as well as advanced stages. The other place where functional imaging can be useful is for patients with Birt-Hogg-Dubé. It is unique in that there are multiple histologies in these patients. They have a variety of tumors along the chromophobe oncocytoma spectrum, including hybrid tumors, but around 10% also develop clear cell kidney cancer tumors. So functional imaging may help us differentiate these. And there's really two examples for this. One is using cestamide, and this is a scan that's basically a mitochondrial imaging agent. And in the sporadic population, it's found that oncocytomas and hybrid tumors have high uptake of cestamide. And the scan on the right, let's see, it's not advancing. Oops. Can we go back to the, go back please? Okay. The video is not working, but the scan on the right shows a patient with Birt-Hogg-Dubé who has cestamide positive hybrid tumors, which gives us a lot of confidence in doing a nephron sparing procedure because these are not biologically aggressive tumors. Contrast that to a patient with a clear cell kidney cancer where an imaging agent like girentuximab, a monoclonal antibody against CA9, has been shown to have high sensitivity and specificity for clear cell kidney cancer. This was shown by Brian Shook and colleagues last year in the Lancet Oncology. So my time is running low, so just to summarize, hereditary kidney cancers have different screening and surveillance schedules based on the individual syndrome, tumor size, and growth kinetics. Conventional imaging can give us insights into the biology of these tumors, both in terms of growth rates and risk of malignancy. And functional imaging may help us differentiate histologies, particularly hybrid versus clear cell tumors in Birt-Hogg-Dubé. I'd like to acknowledge the whole group at the NCI, Dr. Linehan, Ashkan Maliere in radiology, Ram Srinivasan, and the whole crew at the NCI. Thank you very much.
Open the floor for questions. Yes, it's coming behind you.
Thank you, Mark, for the great talk. My question was a little bit related to the TracerX studies which came out from the British groups, and they had talked about that the cells which eventually lead to development of clear cell venous cell carcinoma, they get incepted by the chromosomal aberrations quite early, like even from adolescence, and then they accrue mutations, and then there is a critical clinical mass at some point when it becomes perhaps clinically manifest. So I was just wondering, with the now possibility of prostate multiparametric MRI picking up as little as 5 millimeter tumors, do you envision that imaging for renal tumors or perhaps MRI might be able to detect such early tumors during the inception stage, or while possibly not not feasible for population screening because of cost, but is that even conceptually possible?
It's a great question. So can imaging, either multiparametric MRI or other imaging, pick up early tumors maybe before they're currently clinically visible? Right now, the resolution of MRI, it's when you get into the kind of sub 7 millimeter-ish, it's very tough to characterize this, and we see this a lot in HLRCC. It's tough to characterize using conventional multiparametric MRI. I think the future, if we're thinking about metabolic imaging, we might be able to have a smaller resolution. Not quite there yet, but it's something that's on our minds, and I think it brings up another question: is how practical is that at the population screening level? Probably not so much now, but as costs come down in the future, maybe so.
Hi, yeah, it was a really nice talk. My question is sort of simplistically at the patient level. I mean, there's a benefit to scan ratio, but many of these patients are really young, and especially with the HLRCC that's getting annual testing, is there any concern regarding the number of CT scans that they're getting in general or over their lifetime?
Yeah, absolutely. We want to be very judicious with radiation exposure. So at our institution, we do MRIs to avoid radiation. We don't rely on ultrasound. We don't use CTs routinely. There is a role here and there, but our mainstay of screening and surveillance is MRI.
One thing Dr. Ball said in his elegant talk about that, about the annual screening. We think about this all the time with HLRCC. I'm sad to tell you that we've had at least one patient who didn't have screening 36 months, showed up with locally metastatic disease, went on to develop metastatic disease that was fatal. We have another patient at 48 months. So as Dr. Ball said, we do MRs, but with HLRCC anyway, we're nervous about waiting too long for imaging. I don't mean to be a pain here, but in our experience, ultrasound needs MR.
Okay. And I'll throw out there from the speak that the presentation we had right before lunch, right, and thinking about advocacy and some of those realms, and specifically they talked about the story and the need for navigation, right, that I think these are places that when somebody needs annual screening for a hereditary condition, right, we are not used to screening unaffected young people for cancer. And so they fall into this unique category where we really need to be ensuring that we're providing navigation, that we're able to navigate kind of these processes, because that is a unique process. And so I think you bring up a really great point that we see often in the genetic counseling space. We're going to transition out of the germline positive space and into the germline negative space and have Lindsey Byrne talk to us from the Ohio State University about kind of thoughts on screening family members in germline negative settings.
Much shorter than everybody else. So. Thanks for having me to speak today. I'm happy to provide the genetic counseling perspective. So I was tasked to talk a little bit about the role of a genetic counselor in a GU-specific clinic, as well as then highlight the discrepancies in screening guidelines for individuals with familial renal cancer risk and negative germline testing. So in order to do this, I actually am going to talk about two different research studies that I worked on at OSU. The first one was ran by my student, Jenna, who just graduated, so great for her. What she did is she did a chart review that looked at data from 2017 all the way to 2022. And this data was helpful because I actually started our GU genetics clinic in 2019. So it provided some data before I was embedded in our clinic and then after to get a sense of, what the field looked like at OSU in regards to patients getting genetic counseling and genetic testing. And so what Jenna found was that there were 377 people total referred, with about 240 people who actually got genetic testing. And then what that really showed is that there was a 253 increase in genetic testing, genetic counseling referrals. So obviously, based off of this data, we feel very strongly at OSU that embedding a genetic counselor really increases the conversations about genetic counseling and genetic testing, and so patients are getting better access. So really, we think pairing with genetic counselors would really help your patients to get access to genetic testing at this point. If you're interested in some of the result data, I put that here. We found about a 15% positive result intake from our patients. Happy to talk about that more if you want to reach out to me. I don't have enough time to talk today about it. But most of the time, what I really want to talk about is we're able to get patients to genetics and identify the positives. And as we know, majority of our patients are going to test negative. So what are we doing with families that test negative and their family members who are now worried about kidney cancer, whether their sibling had a young cancer or there's multiple relatives with cancer? We in genetic counseling get this question a lot because we talk to not only the patient, but we talk to the family members. And so myself and 4 other genetic counselors got some grant funding money from the National Society of Genetic Counseling to really look at this idea to see how can we assess the current practices regarding screening recommendations for patients with familial RCC risk, evaluate the perceived need for these formalized screening guidelines, and identify the right people at the table to create these guidelines. And so what we did was send out a survey to all providers, and especially people who took care of kidney cancer patients. 70 people replied to our survey, and so most of those people were genetic counselors, but we also had medical oncologists as well as other folks reply. These folks had a varied amount of experience, but most of them were in the 0 to 5 range of years in the field, as well as we wanted to see how much genetic exposure did these individuals have, and most of them have had some type of very specific genetics training. 89% of these individuals were female and reported to be white, non-Hispanic, but we did have 9 individuals report as Asian. All of these individuals tended to be under the age of 60. What was also important to us is to get a sense of how comfortable were the people who replied to the survey with hereditary conditions. And we found that the majority either were moderately or extremely familiar with hereditary syndromes, so that was good news for us. The other piece that we wanted to gauge is we came up with 5 hypothetical scenarios to say, if these scenarios presented, would you agree, disagree, or would you be unsure to provide screening recommendations to these families if the proband or the patient in front of you with kidney cancer tested negative? As you can see, the replies were varied, and that's more what we expected because this area has been so conflicting right now. But to point out, we found that the most agreeance was when we saw a patient who had RCC, and then there were 2 family members, first degree specifically, who had RCC. So that's a pretty high risk of kidney cancer in that family, and so that made sense to us that that was one that people would feel pretty comfortable screening. The one that had the least agreeance was a patient with multifocal disease. So as we dug into the survey a little bit more, we wanted to get a sense of, were patients inquiring about RCC to their family members, as well as were they asking about screening recommendations? And both of these questions showed about 84% that either sometimes, often, or always patients were presenting with these questions. And additionally, we really wanted to ask specifically, when you have a patient who has a personal history of RCC and negative germline testing, are you recommending screening recommendations to family members? So 5 people said yes, 20 people said no, and then 45 people said on a case-by-case scenario. So we broke down those case-by-case scenarios to give an idea of different themes. And the strongest theme that we were seeing was it really depended if there was family history or what was the age of the proband and relatives. as well as we also saw a theme of we're going to refer this patient to other healthcare providers to make that decision. And that theme made sense to us who ran the study because a lot of us genetic counselors use that kind of language to send patients back to urology or primary care. So when people said they were not screening, what was their reasoning? What was going through the reasoning of like, why wouldn't you want to screen? And strongly, 61% of people said there are no guidelines to determine when empiric risk recommendations are warranted. And so that then brought us to say, do you think we should have empiric risk screening guidelines? And 91% of these people said yes. So it's very strongly from this survey that we need to get something written so that we can help guide us in the field to help our family members as well. The other thing that we wanted to look at is, well, what are some themes that we saw when we looked at people who said, yes, what's your opinion on saying we wanted screening? Consistently, people wrote in the text box that they really wanted consistent guidelines and that there's empiric risk guidelines for other types of cancer. Why don't we have something for kidney? So with that all said, we then asked the participants, well, who should be at the table to make these guidelines? And the three top were genetic counselors, urologists, and medical oncologists. So in conclusion, this was the first study regarding provider perspectives on RCC screening and germline negative or familial RCC risk. These findings highlight the need for consensus-driven and evidence-based guidelines. These guidelines would then create consistent clinical care, improve patient-provider communication, and then align with other cancer empiric risk guidelines like breast and colon. So now what? What do we do? What are the next steps? Well, based on this survey, it feels like we need to develop some type of standardized recommendations with numerous different topics, like including what type of imaging should we be using, at what frequency, what features of the proban's cancer matter. Is it age? Is it how large, like those pieces? And then thinking about family members. Is it the family history matter? How many? And I'm sure there's more questions too, but those are the most common that came to mind for us. So with that all said, I can't say a bigger thank you to anybody outside of on this slide because this work was done by numerous people. So I just wanted to say thanks and thank you for having me speak today.
Yep.
Thank you. Great talk. We've had very similar discussions in the UK around this topic and come to sort of similar conclusions in a expert and patient forum rather than by questionnaire. The big unanswered question and disagreement was around who would deliver this, because potentially there's quite an explosion of work that would be associated with it. I don't know if you'd had thoughts about that, or whether from any of the other areas where this type of thing happened, you had any recommendations.
Great question, and no, I haven't quite thought about that, but I feel like there could be some type of model with maybe using nurse practitioners or PAs to help get the screening protocol set up. I don't know, but that's a great thought to add to this discussion too.
Dr. Brugos.
Yeah, so great session. To follow up on that, a couple of things. One, Maria, I think if I recall correctly, you mentioned you had 90 patients with clear cell in a young age that were not diagnosed with genetic testing. I wonder how you handled that and whether you have looked or planning to look at the frequency of relatives developing cancer in the same families. For me, practically, when I see a young patient, I generally, and they have children, I generally tell them to consider that the children should discuss their father's or mother's condition with their doctor and consider beginning screening 10 years earlier. I don't know how you guys handle that.
So for young clear cell patients without a family history, we do not routinely recommend screening for, say, siblings or relatives in the absence of a mutation or other syndromic features, although we try to enroll them in studies and recommend they follow. I mean, these patients, they've had cancer, so they tend to follow up with us, and I actually don't discharge them from surveillance because I don't know if this is their first cancer, but they're going to get another one, you know, at 40 and 50. But if it's a singleton case of clear cell, we do not routinely recommend screening for the relatives. Now, we follow, you know, our practice within our genetics group is if you have two relatives with kidney cancer, first and second degree, we do have some vague language in our notes that says consider screening, and we send them back to their PCP. I realize that's not ideal, but that's our practice. And again, we try to enroll as many as we can in studies, genomic studies to study their tumor. Because one thing is, if you have two clear cell cases, you sequence them, and they don't have a VHL mutation, but everything else, you know, screams clear cell, like 3P loss, then I suspect a cryptic VHL mutation that I can't identify. Versus if they have a plain old clear cell, two siblings, you know, I say maybe it's just chance. Hopefully.
So, question, I think they are saying that we are seeing increasing rates of cancer among young people, breast, colorectal, kidney, right? And the 30s, 40s, even in their 20s. And then a lot of the germline testing has been negative.
Can you see,
Yeah, thank you. A lot of those patients have negative germline testing. So I really think we need to focus on also the environment, study the environment. I mean, the focus is because they're young, let's do more genetic testing. Well, yeah, sure, we should do that. But I really think, in my opinion, the environment is the culprit here in these rising cases. And it's pollution, it's diet, it's, you know, all those things. So what are maybe next year we need to have a session on, you know, environmental hazards and especially in Boston.
As everybody holds up their sodas.
Exactly.
Yeah, for the under 50 crowd, I wonder all that high C that I drank as a kid. No, yes, I agree, because it's not just kidney cancer, right?
I think that transitions really well to our last speaker, Dr. Stewart, who comes from the UK and is going to talk a little bit more about population-based screening for patients, again, without a known genetic pathogenic variant. So, Dr. Green.
Thank you very much. So yes, so I'm going to talk about risk-stratified screening for sporadic kidney cancer. Here are my disclosures. So why would we open this can of worms that is screening for kidney cancer? Well, I think that there are two main ways that we can improve outcomes from kidney cancer. One is to improve the treatment of high-risk localized disease, and the other is to detect disease early, potentially by screening. And if you look at data from the National Health Service, you can see that we identify disease earlier, we can cure more people, but also it costs a lot less to do that. So long story short, my group have done a lot of work on this topic over the years, and it all came from questions of our patients in the clinic over, you've detected my disease by chance, why is there no screening program? So to summarize where we got to, we basically got to the point of saying we've got enough evidence, there's enough public opinion that we should be looking at this, and we need to run a clinical trial. So we've undertaken a feasibility study of screening for kidney cancer called the Yorkshire Kidney Screening Trial, and I'm going to talk through the results of that for you today. So the point here is that kidney cancer is a disease of relatively low prevalence, so a standalone screening program is highly unlikely ever to happen. But there are opportunities to take advantage of other screening programs that we can bolt ourselves onto. So one key one is lung cancer screening, which exists in several countries, including the US, including the UK. And of course, the risk stratifier there is smoking. So being a current smoker or an ex-smoker of a certain level of smoking history, and that's clearly a very strong risk factor for kidney cancer. There are other risk factors, but smoking is a strong risk factor. So in YKST, as we called the study, we aim to assess the feasibility of adding abdominal non-contrast CT to look for kidney cancer and other abdominal pathology to the CT scan of the chest that's offered within lung cancer screening. So this study was embedded within an existing lung cancer screening trial that was taking place in Yorkshire in the UK, which is an area of quite low socioeconomic deprivation. It was screening people that were attending for that program, so it was 55 to 80-year-olds with a certain level of smoking risk between 21 and 22. The primary outcomes of this study were to evaluate whether people would agree to have the scan done when offered to them. Was it acceptable to them? Was it acceptable to healthcare professionals who were involved in the process? The secondary outcomes will be of great interest to this group. So what were the proportion of people having a renal cancer? What was the stage distribution of that disease? What were the proportions of incidental renal findings that we potentially didn't want to find? And what were the proportion of non-renal findings like aneurysms, other cancers of the abdomen? So almost 4,500 people attended for lung cancer screening during the inclusion period. 97% were eligible to be offered our additional scan, and a very high level of acceptance. 93% of people accepted the scan when they were offered it on the day of their lung scan. There were some groups where uptake was lower: older people, women, and current smokers. We undertook an acceptability phase to this study, which was a questionnaire-based approach of 500 participants. There was a very good response rate. It didn't matter whether the person had a normal scan, an abnormal scan requiring no further action, or an abnormal scan that did require some further action. The satisfaction levels were high, and decisional regret was low for having the scan. So here are the outcomes from the scans. So we did 4,019 people agreed to have a non-contrast CT of the abdomen. 2/3 of them had a normal CT and were sent a letter reassuring them of this. The other third of people were then reviewed in our imaging review meeting, and the following outcomes you see there took place. Of most importance, 15% of people needed some form of further evaluation, either invitation to a clinic, a non-urology clinic, a urology clinic, or going on into a cancer pathway to have a contrast-enhanced CT and review in our MDT because we thought that they might have a urological cancer. We split the findings out into serious and non-serious. So serious were either a threat to your lifespan or to your quality of life. And the most key things to point out here were that 5.3% of all of the people scanned had a serious finding. The most important for this audience are that 0.25% had a new kidney cancer, 3/4 of which were low stage 1A. So these were histologically proven. There were about 1% of people who had a renal lesion of some description that needed further evaluation. Exactly the same proportion, 0.25%, had a different abdominal cancer, and 1.5% of people had a new abdominal aortic aneurysm. Now, of course, the flip side of the coin is what proportion of people had a non-serious finding. Well, this occurred in 25% of participants. The vast majority of these were other renal findings, so cysts or small stones. The key thing here, though, is that only 6% of people who were scanned needed any further investigations to identify that this was a non-serious finding and didn't need any further management. All of the others could be identified on the original screening CT. Now, you might be saying 0.25% of people with a new kidney cancer, that doesn't seem very much. But actually, when we look in the context of what screening programs pick up, it's worth sort of considering the numbers. So I told you that all the serious findings were 5.3%. But if we go to the next line down, you see all proven cancers or abdominal aortic aneurysms. That was 2% of all of the people in our study, which is more, as a higher prevalence than you would expect to see for lung cancers, breast cancer screening, bowel cancer screening. And even when we get down to the proven cancers and proven renal cancers, they sort of fit into the ballpark that we are starting to get from other cancer screening. The other thing to, of course, consider is the cost effectiveness. We did a cost effectiveness analysis based on our data, and as you know, in the UK, we have this thing called the NICE process, National Institute for Health and Care Excellence, which determines whether a new treatment can be licensed. Well, this falls well within the ISA per QALY that's required for that. So what's next? So essentially we've shown feasibility, that people will have the scan. We've got a rough idea of the findings that we would get. But of course we don't know anything about disease-specific survival or stage shifts, and that needs to be understood in a randomized way. So our next step is to pilot a randomized controlled trial in a live lung cancer screening program. That's work that's being funded and undertaken again in Yorkshire. It's being funded by Yorkshire Cancer Research. So it's going to be a feasibility study called Tactical 1 of adding and doing in a randomized way the non-contrast abdo to the non-contrast CT, comparing with the CT scans of the thorax only, in a tighter age range that we've identified from our health economics as the most economically viable age range. So I'll finish there and just thank the large group that have helped with these studies to date.
Great work.
Grant, great talk. With your last screening, imaging, are you incorporating liquid biopsies? Because, you know, this could be the future and all your endeavor here.
Yeah, so actually in the study I presented, the lung team had already started collecting liquid biopsies at baseline. So we've got a great opportunity there to look at KIM1 and others. So it's exciting, because clearly that would be the ideal scenario, wouldn't it? That you could potentially use that as part of the triaging step.
Yeah, question for Maria. BAP1-driven tumor, when it's pathogenic, whether somatic or germline, some folks have advocated PARP inhibitor just based on the biology, but I think in a couple of cases, part of some trials, it did not pan out. Do you think we still should hamper on DNA damaging agent for this later refractory patients?
I'm going to phone a friend. Ritesh, is he around?
Ritesh.
He published.
Ritesh.
There he is.
Were there any BAP1 patients in your...
Oh.
I'm into soccer, not
So, it's a great question, Tony. We had two trials that we did at Memorial, both in the combination space, so PARP inhibitor plus immune therapy and PARP inhibitor plus TKI. And in both those trials, we had clear cell RCC patients with very few numbers, but there were BAP1 patients, and we didn't see a significant response. And the PARP inhibitor there was talazoparib. To your point, there have been some case reports of BAP1, and I know that if Yasser is here from Hopkins, we can phone another friend, but as certainly... Certainly, he could comment on that.
Let's have a relay throw, maybe.
My hunch is, you know, there are other BAP1 mutated cancers like mesothelioma, melanoma, and they don't tend to respond to PARPs. So.
Yeah, I'd say we have the trial with olaparib in patient with RCC with DDR alterations, including BAP1, and we're seeing some activity, but it's in contrast to what the other studies have shown, but we're still trying to learn more if there is something beyond BAP1 which explains the responses. So.
I think we'll also just put a question out to the crowd, which is something that we've chatted about, which I think is really just related to this idea of questions from family, things that have, kind of what arises in clinic and how we can think about the support of continued incorporation of genomic services into kidney cancer care. And we'd open to the audience for any thoughts, not just questions.
Hi, Wesley from City of Hope. Separate question from the whole panel. Yeah. We have a really amazing genetics team that's very fast and easy to access, but most of these masses are seen by community urologists who don't have that.
Yeah.
And I was wondering, I guess, how to expand testing more easily to the community where a lot of these patients are, or should we be encouraging centralized testing and actually just referring to specialized centers?
I mean, I always have thoughts, but I will leave it to the, okay. I mean, I think you bring up a really great question, right? We talk about, kind of living in that castle on the hill in an academic center where we have sufficient genetic counseling services, right? You're able to go through that genetic testing, or you've had time to have the sufficient training to be able to do that pretest counseling yourself. You have a strong nurse navigation and or nursing team, right? And that is not what happens in the community clinic. We know that's not what happens in urology. And so in urologic settings, specifically in community clinics, I've seen some really nice models in institutions I've worked at and collaborating partners where they've been able to do partnerships. But I think some of the key to this is collaboration. And I am going to use an example from the genetic counseling space, but it's a model that I think we should be thinking about big picture. So when we think about how genetic counselors partner with clinicians, we have one of four options. The first is what we call a traditional approach, right? You refer to us, we do genetic testing, we send the patient back to you. The second is tandem, where you essentially do it as a team, right? You may order it, we may order it, we kind of do it back and forth in this mechanism that says that the expertise goes between the two. And the third mechanism is kind of a consult service, where genetic counseling sits as the back end, right? You lead the process and we are here as the experts. And then the one we want to avoid is the rescue process, right? Where somebody is uninformed, they don't quite know what they're doing, and now a 25-year-old with a BRCA mutation has her ovaries removed 20 years before the guidelines would have said so, right? That is the worst case scenario. And so I will speak on behalf of genetic counseling, but also in terms of the other settings, that we need to be doing a better job of multidisciplinary collaboration, right? I also work in paraganglioma pheochromocytoma, and when I have a patient that needs to be seen and the endocrinology wait is 9 months, I call the endocrinologist and I say, hey, I think this is more urgent than that. And I think we need to be doing that with community clinics. We need to be doing more outreach and work. And I think as we've talked about funding crunches, those are the things that are coming under fire amidst many, many other things, right? And so there is a need for us to continue to collaborate and ask community centers what they need and how we can really think about prioritization and triaging in these settings.
To add to that, genetic testing companies have helped with this because now we can do mobile phlebotomy and video and phone appointments. So even though I'm in the center in Columbus, I see patients all over the state of Ohio and can get them genetic testing, and we can video, we can phone, and do all of that with them staying at their house all the way up in Toledo on the border, and even all the way south as far as Cincinnati. So I think there are becoming more options where large centers can do much more outreach, and we also partner with local community hospitals, and they will utilize our genetic services in certain pathways like what Sam was just talking about as well.
I think that brings us close to time. So with that, I'd like to thank all of our panelists, all of you for your time and your attention, KCRS for giving us the platform to discuss this, this really exciting and innovative space in kidney cancer. So thank you all.
Thanks, everyone.